For patients whose dispatch is altered mental status, we want to make sure we respond quickly and aggressively to the call because we understand that brain health is difficult to treat when something goes wrong, and if somebody is having a stroke, we want to make sure that is detected as quickly as possible so we can bring them to definitive care as quickly as possible. Brain tissue does not last very long in a hypoxic condition, and we don't want to waste time that we don't have to waste. So for a call with the dispatch is altered mental status, we want to make sure that the scene is safe. We want to make sure that as we move around the patient that we're not going to trip over anything. We want to make sure that our PPE is on for this particular call. This is going to be gloves. It is going to be a simple mask. We don't expect any aerosol generating techniques to take place. We want to make sure that we understand that there's going to be one patient, that it is ALS criteria when it comes to altered mental status. That way, if we need ALS, they'll already be on the way. The nature of the illness itself is going to be altered mental status. We may not know the exact etiology, but we want to proceed aggressively, and we are going to keep the C-spine considerations in the forefront of our mind. We know that brain injuries can be caused by trips and falls, and what caused the altered mental status might have also caused cerebral spinal injury, but we'll take that as it comes. So I'm going to come in, place my bag at the patient's feet so I can avoid any tripping issues. I want to introduce myself. Hi, sir. My name is Matt. I'm from the Union County College First Aid Squad. How can I help you today? The patient he says that his name is John, that he has a bit of a foggy feeling, and that he can't remember the last few minutes, and that his wife is particularly scared. Sorry to hear that. Is it okay if I treat you? Well, I want to make sure that as we enter a patient with an altered mental status, this personal space, that we have their consent and that we are not going to act in an abrupt way that might cause them alarm. The patient says yes, you can check him out. So I can feel that he's pale, that he's cold, and that he's sweaty, and that his pulse is a little bit elevated. So he tells me that his name is John, and I ask him, is this your house, John? He says yes. I ask him what time it is, and he tells me that he does not know. So my patient is awake, they are alert, but they are only oriented ×2, person in place. They're not oriented times time. And this is going to be the first flag to me that the patient has an altered mental status. As far as I can tell, the patient does not have dementia. There's no indication that that would be the case. So I will assume that this is a departure from the normal from him, and that I need to check him out for signs of stroke, for signs of diabetic emergency, and finally signs of a seizure having happened. All right, sir, so I'm going to ask you a few questions. Are you having any difficulty standing right now, balancing, falling, or anything like that? So the patient says that he's not having any difficulty with balance or moving around, that he's able to walk without any issues. All right, so do you have any additional problems with your eyes? Have you trouble seeing? Can you see my hand when it's over here? Okay. How about over here? Can you see my hand okay? Now, does anything seem blurry to you? I'm going to check his pupils as well. The pupils seem normal. Okay, so his vision doesn't seem to be affected by the problem today. All right, sir, so I want you to give me a big smile from ear to ear. I'm asking my patient to smile to see if there's any facial asymmetry. He gives me a big smile. It doesn't seem like there's anything out of the ordinary. All right, sir, so I'm going to ask you to just hold your arms out and just hold them there. All right, close your eyes, and I'm going to let go, and I want you to just hold them. Okay, so the patient is able to hold out his arms away from his body without any difficulty. Any kind of asymmetry might tell me that this could be a stroke. Now, the way the patient is speaking to me doesn't suggest any slurring, but if the patient is giving you short, one-word answers, sometimes it's helpful to have the patient read a phrase to you. Sir, could you please repeat after me? The sky is blue in Cincinnati. He repeats after me, and everything seems okay. If the patient had slurred his speech, if the patient had a drooping arm or an arm that drifts off to the side, or any kind of facial droop, that's a sign of a stroke. If the patient had any difficulty seeing, if the patient had any difficulty with their balance, those are also signs of a stroke. If the patient tests positive in any of these categories, we should proceed to the hospital under your own squad's code stroke protocols. But everything seems fine with this. Okay? Now, as I look around the patient, I'm also going to see if there's any signs of seizure, any kind of tipped over furniture, any kind of, disorganization around him that would suggest that he fell. I'm looking for signs of incontinence. I checked his eyes before. I was able to see if he had fixed and dilated pupils or any other signs of seizure there. Patient doesn't have any injuries to his face that would suggest a seizure, such as a bent tongue, missing teeth, bloody lips, or anything like that. And I don't see any signs of medical alert tags. So I don't think that this patient had a seizure, but just to be sure, sir, you don't have a seizure disorder, do you? Such as epilepsy or anything along those lines. The patient says no. Okay, so in the absence of all those things, I don't think that they had a seizure. So with those two out of the way, I want to ask the patient, sir, are you diabetic? The patient says that he is. Diabetic emergencies are an extremely common call. The one we're worried about more than any of the others is going to be hypoglycemia, or low blood sugar. The big signs of low blood sugar are going to be pale, cold, and sweaty skin, which we verified before was the case, fast onset, and diminished mental capacity. The patient's going to be drowsy. So, sir, have you checked your blood sugar lately? They say no. If the patient has their own glucometer, you can feel free to have them check it themselves. But in the state of New Jersey, it is beyond the EMT scope of practice to take a glucometer reading, but just understand that any reading between 80 and 120 is considered normal for a patient in this condition. So I'm going to ask the OPQRC and sample questions. Sir, what were you doing when this started? The patient says nothing in particular. It came on gradually. Okay, so is there anything that seems to make it feel better or worse? You tell it seems to be getting worse over time. Is there any way it makes you feel? The patient says foggy, groggy, hungry, thirsty. Okay. Is it just the foggy feeling, or is there any other part of your body that feels like you feel weak, difficult to stand? The patient says yes, it feels difficult to stand. So has this ever happened before? He says yes, a few times. On a scale of 1 to 10, 10 being the worst that this has ever been, where does this rank along those lines? The patient says a 6 or a 7. Okay, so the patient said that this has been happening over the last several hours. It's been getting gradually worse. Okay, so have you done anything to kind of get ahead of this? Have you eaten anything or anything like that? The patient says that he doesn't have any food in the house, that he would normally have eaten some sort of snack, but none was available to him, so he was waiting for somebody else to bring them food, and it just wasn't here in time. Okay, so, sir, do you have any allergies to any medications, environmental stuff? He says no. Medication-wise, what do you take? Patient says they take insulin, and they take Vasitec, two extremely common drugs for diabetic patients. All right, sir, do you have any medical problems other than the diabetes? I have high blood pressure. Okay, the diabetes, is it type 1 or is it type 2 diabetes? He says it's type 1, insulin-dependent diabetic. Okay, what was the last thing you ate, and when did you eat it? Patient says they ate something about 6 or 8 hours ago, and that it was a light lunch. All right, so that leads me to believe that the patient didn't eat enough food to cover the insulin that they had taken. All right, sir, so I have only one final question for you. Is there anything that's been happening over the last few days that would suggest that you had maybe you were sick or had the flu or anything like that? And the patient says no, they haven't. Now, while I was doing my interview, my partner was doing the vital signs. In this particular type of call, there's no one vital sign that kind of outranks the others. They just need to make sure they take the pulse oximeter, the pulse, the blood pressure, the lung sounds, the respiration rate, and finally the eyes, which we took at the beginning. Okay, so with that out of the way, I think my patient is awake enough to take glucose gel. The one contraindication to glucose gel is going to be the inability for a patient to swallow and therefore control their own airway. In each of our bags, we carry 15 milligram glucose gels along with a tongue depressor on which to put it. So we're going to instruct the patient to simply hold the glucose gel on the inside of their mouth, on the inside of their cheek. You're going to instruct the patient, do your best to not swallow. Now the way it works is we're going to place a portion of the tube on the side of this tongue depressor. You're not going to get it all, but you'll be able to fit roughly a quarter to a third. And you're going to place it into the space between their cheek and their gums. This is called the intrabuccal route. It's going to allow that sugar to dissolve directly into the mucous membranes of their mouth. They are going to inevitably swallow some, and that's okay, but we want them to absorb as much as they can, as quickly as they can, and having it go through their mouth wall is the fastest way to do that. So you're going to repeat taking it out and placing the next portion on until there is no more gel left, and then you can simply discard the garbage. For a patient of an adult male size, this is not going to raise their blood sugar very much for very long. They are going to have some sort of substantial food if we are going to let them go. Many of your patients will require transport, and also many of your patients will request an RMA. An RMA is within their legal rights to do, and you just need to make sure that their consent is informed. If you're going to transport them, I recommend getting them food regardless. This is only going to raise the blood sugar of a gentleman this size for about 20 points for about 20 minutes, which isn't that long. A little bit more substantial food would be better. If the patient does want to RMA, they are entitled to do so, but we need to make sure that they are not going to call us back after a short period of time. This is going to wear off fast. So in particular, we want to make sure that if they can find supervision for themselves, they should. So if they have a family member who can look after them, so much the better. For food, we want to make sure they have simple and complex foods in their stomach. So this usually includes complex carbohydrates, sugars, and then a choice of either protein or fat. So a glass of orange juice being used to wash down a peanut butter and jelly sandwich is a great fit. It's got all of those categories covered, and it's going to stabilize their blood sugar at the number it should be. Finally, they're going to have to be alert and oriented times 3. If they're not alert and oriented times 3, they are not allowed to legally RMA. So they need to be able to articulate their name, where they are, and what just happened to them. If they could do these things, make sure they fill out the proper paperwork according to your department's procedures, and then you can wish them well.